Hello, my name is Mudra, an undergrad student at the University of Manitoba in Winnipeg, Manitoba in Canada, and I will be presenting some of our findings on whether there is an association between preoperative audit C-scores and postoperative delirium in cardiac surgery patients. On average, 164 million people have been diagnosed with alcohol use disorder around the world, and alcohol use has been identified to be a risk factor of postoperative delirium. And so to identify alcohol use disorder preoperatively amongst cardiac surgery patients, our center uses the AUDIT tool. It is short for the Alcohol Use Disorders Identification Test Concise. It is basically a tool made up of 3 questions, like how often do you have a drink containing alcohol? How many standard drinks containing alcohol do you have in a typical day? And how often do you have 6 or more drinks on one occasion? So an individual can score anywhere from 0 through 12, 0 meaning no alcohol use, greater than or equal to 4 for males, and greater than or equal to 3 for females classifies as alcohol misuse, and greater than or equal to 7 classifies as high alcohol consumption. That being said, when we look to find evidence on whether alcohol use actually predicted delirium in cardiac surgery patients, astonishingly, there's very little data supporting it. And so the objective of this study was to determine whether preoperative alcohol consumption measured by the AUDIT is predictive of postoperative delirium. And so we hypothesized that higher AUDIT scores, meaning higher alcohol consumption, would be associated with a higher incidence of postoperative delirium. This was a single center study. We looked at 4,964 patients, out of which 1,416 had an available AUDIT score right from March of 2015 to September of 2020. We then calculated the delirium rates for each of the AUDIT scores, so right from 0 through 12. And we used a multivariable logistic regression model, which controlled for age, sex, previous stroke, MOCA, diabetes, chronic kidney disease, recreational drug use, anxiety medications and antipsychotics, procedure type, frailty score, urgency, pump time, and mechanical vent time. And we categorized the data into 3 categories: any alcohol consumption, alcohol misuse, and high alcohol use. In the first category, we looked at individuals who scored a 0 on the AUDIT, meaning no alcohol use, which is shown on the graph here, the green colored graph, as no, as we see that individuals who had no alcohol use had higher rates of postoperative delirium, which was classified as CAM positive. Simply put, no alcohol use was associated with higher rates of delirium. When we stratified the data by age and sex, we found that older adults reporting no alcohol intake and patients of the female sex had a higher incidence of postoperative delirium. Similarly, when we looked at the alcohol misuse category, we found that individuals who classified as misusing alcohol, characterized as yes on the first yellow-colored graph, had low post-op delirium rate, meaning alcohol misuse may not be associated with postoperative delirium. Stratifying the data by age and sex showcased that both age groups and both sexes, so male and female, identified as misusing alcohol, experienced lower incidence of postoperative delirium. In the third category of high alcohol consumption, we did not see a statistical difference between the high alcohol consumption group, characterized as yes on the first blue-colored graph, and in the individuals who scored lower than 7. When we stratified the data, we saw that older adult patients with high alcohol use may actually have a lower delirium incidence. Overall, when we stratified the data by preoperative clinical frailty scale score, we saw that frail patients with varying amounts of alcohol use may have had a higher, if not equivalent, rate of postoperative delirium. So though the findings of this inquiry are quite novel, there were some limitations to consider. This was a single center study, and the AUDIT tool was a self-reported tool, which did require the patients to be forthcoming with their alcohol consumption. And due to the current backlog on the cardiac surgery research database, we were not able to identify the subtypes of delirium for this particular sample of patients. So to summarize, surprisingly, alcohol use measured using the AUDIT was not predictive of postoperative delirium in cardiac surgery patients. And we recognize that future research could investigate the unanticipated finding of higher rates of delirium in individuals who reported minimal to no alcohol intake. This study could not have been possible without the support and guidance from Brett, Dave, and my mentor, Dr. Rakesh Arora. Thank you very much for the opportunity to present at the American Delirium Society conference, and I look forward to interacting with all of you virtually. Thank you.